Kigezi sub-region of western Uganda is known for many unusual things, including the seemingly active population operating day and night. One does not have to spend much time here to be familiar with exceptional terrain that seems to be the welcoming factor in the area. Such uniqueness is making it a tourist attraction and a hospitable site for service seekers from neighboring countries. Here we can talk of Rwanda and the Democratic Republic of Congo, whose natives seek health services from the neighboring district of Kisoro in western Uganda.
There is a consistent ignoring of the fact that the solutions of the problems of people is in the people themselves. And whoever tries to do it at the center is just having a black curtain in front of them, and nothing will work.
But imagine a situation where the services are only planned for the locals, but foreigners somehow also get to benefit from the same.
I have 80.
That is the exact situation Kisoro district is going through, apparently limited by resources and overwhelmed by the number of patients, especially from Congo, who are not catered for during planning and budgeting.
We have 4,421. Those are the patients enrolled so far in the HIV care. All over Kisoro district, we have even those ones outside the district.
Esther Mahoro is a nursing officer employed at Kisoro Government Hospital. She says among the ailments whose treatment service is sought here include HIV/AIDS, tuberculosis and malaria, with the standing of children being serious.
At least every man who comes for ANC is tested for HIV. And those who are found positive, of course, they start immediately. They start them immediately on act.
However, with insufficient staff to handle all patients, this poses a challenge. There are not enough drugs, yet even third-line treatment of HIV/AIDS patients is lacking.
We don't have nevirapine syrup, which has disappeared for almost a year.
Where does this leave the health of residents in this area, especially when it comes to treatment of HIV/AIDS? This question emanates from the fact that such challenges are not confined only to Kisoro Hospital. At Chahafi Health Center 4, there are no cases of gender-based violence, a reason for which more families living positively have been attracted. Even when the area is not challenged by the presence of truck drivers, HIV/AIDS still spreads from outside the area. The situation is exacerbated by mothers from neighboring Rwanda who declined to seek treatment.
We have PITC, we have also VCT, and after someone has become positive, we link him to or her to care. Initially, we are putting them in pre-art, but before that, we also have the services of CD4 as a basis for the start of treatment.
Kabale district is not any better. When it comes to supply of medicine, it's another story, as people from Rwanda also share the little supplies with the locals. Mande Medad is the store's assistant, Kamwezi Health Center 4.
During the upsurge of malaria, like in these months, we get a lot of people from Rwanda across. And you find we have stocks which were planned for our people here, and they are shared. It is shared with the people from across. So they affect our stock levels very much.
Despite the availability of almost all TB drugs, malaria stocks are not enough, Yet national medical stores respond 2 months after orders are placed. As if that is not enough, sometimes deliveries too are not enough, not forgetting some are at the doorsteps of their expiry dates. This implies the supply chain management needs some fixing, especially in the use of consumption data to determine the need and avoid wastage.
But you find you place an order, for instance, for like 40 packets of Coatem, 30 times 24, which is an adult dose. Find the NMS delivers like 5 packets, which are not enough for the people here, for our patients.
These could be some of the challenges that make the health center's staff more determined to soldier on. The presence of the CD4 machine simplifies work, which also makes monitoring of children that are victims of HIV more convenient.
We have the health education talks where we do the health education talks about the prevention of HIV. We have this system of testing everyone who comes, at least at the unit. Then the system of testing the pregnant mothers. Then when we find that is HIV positive, we start the mother on treatment. We follow up during even delivery. We encourage them to deliver at the health facility where we give, like the prevention, we give the nevirapine syrup to all babies who are born to HIV pregnant mothers.
These challenges could probably have been some of the reasons why the country coordinating mechanism for Global Fund embarked on a field tour of Kigezi sub-region. The purpose was to realize the cost effectiveness in implementing healthcare activities with the aim of reaching optimal numbers with quality comprehensive package. This ranged from prevention, care, treatment and adherence for all age groups in ensuring value for money. Dr. Christine Ondoa, the director, Uganda AIDS Commission, was part of the team.
So every year we sample districts and reach them and ascertain on ground what the issues are. And also not only challenges, but some districts also have very, very good practice, and we want to capture that and share it with other districts. As Uganda AIDS Commission, actually the border districts are one of our priority areas. We acknowledge the difficulties borders have and also the uniqueness, especially, concerning trade, concerning refugee populations, and also concerning service delivery.
Various meetings were conducted here, with one of the main agendas being to assess how Global Fund resources were trickling down the main health systems to the intended beneficiaries. A lot was shared, including the challenge of the Batwa community.
Abatwa bafuna sores mu tribes endala ezija Kisoro, because omukiga, omutoro, omudokoli, omusirikale owaze kusuubula tamanyi nti omutwaye mutwa obaki forecast yefunira omuntu wakwebaka naye namuwa omukwano ekyo kimana. Naye nze mu tribe yange, it is abomination to think about even a mutwa for sex, let alone for marriage.
And in ascertaining this further, more field trips were made where a lot was also unearthed.
Kubanga wano embeera ze tulina wano sinungi, kubanga tetulina kyakulya, tubeeraawo nga tetulina ekintu kyonna.
Nsimanya Katonda kubanga twabagamba bayaganye asike twabagamba babeere mano balime bakole ki
singa twalifunye gunde endimiro zaffe netuzibeeramu netwerimira nga terina kunakuna kusina kusabiriza awo twali badde bulungi.
As the team draws to Rugeshi village, Murora sub-county in Kisoro district, the real definition of a hard-to-reach area became apparent. One hill after another, cornered road network with no clear campus direction make access to the area more time-consuming. Time-consuming in all aspects, including the situation locals here endure while seeking medical services, especially in transporting patients to the health centers. Using their unique ambulance that costs 100,000 shillings from craft makers, it is always difficult to save lives as it takes them hours to reach health centers. Rugeshi village chairman Bariarirahe Filippo decries poor communication networks, making communication to health centers problematic, complementing the chief administrative officer's assertion.
We are taking patients at the hospitals, but sometimes they die because those health workers, they don't support us immediately.
And I told them, be it midnight, be it any time of the night, my phones are there and we always act.
The case of Kabale district, which houses the region's referral hospital, is not anywhere different.
When this money comes, we don't actually work only in the Kabale district.
Like yesterday we were in Rwanda.
It's done in the Rwanda district with the Rwanda staff. Because now we are mentoring the TB focal person there, the HIV focal person and malaria focal person. So when it is to be on that side, this team goes, they work together.
All this was brought to the fore during meetings with area officials. A lot of vital information was availed to the CCM team for Global Fund. There is an emerging resistance phenomenon where many patients, especially adolescents and women, are resistant to second-line treatment, hence the need for resistant monitoring, since the third-line regimen isn't at all available within the region.
It's not as if we don't propose what should be done. We do propose what should be done to end this situation permanently. Let me now propose it again, and I hope this time probably you'll add your voice to whoever is concerned.